Awesome. Thanks for the introduction, Dr. Al-Nasser. So my name is Chaitanya. I'm one of the cardiology residents. Today I wanted to present a really interesting learning case, and the title of the presentation is Down the Rabbit Hole, Polymorphic Ventricular Tachycardia Yields an Elusive Diagnosis. So this was an interesting case that we saw at UHN with Dr. Andrew Ha and Dr. Spears. So we've gotten their permission to go ahead and discuss this case for our rounds today. So just a quick disclosure, this presentation does involve the discussion of a direct patient case, and so that patient has provided consent for us to discuss this for educational purposes, but we have mitigated we have changed some aspects of the case to to alter the possibility that the patient could be potentially identified. So our presentation today is for Mr. VT. He's a 28-year-old gentleman. He has a 3-year history of exertional palpitations, headaches, and presyncope, for which he was referred to electrophysiology. His primary reason for referral was that they had done a outpatient Holter and an exercise stress test with general cardiology, and he was found to have some runs of non-sustained ventricular tachycardia. So when we first saw him, we did a pretty thorough history for him. So as far as we knew, he had no past medical history that was previously diagnosed. We did a thorough family history, and there was no prior history of any arrhythmias. He had no underlying structural heart disease and no personal or family history of sudden cardiac death. He wasn't taking any prescription medications and no over-the-counter medications as well. With regard to social history, he lived quite an active lifestyle. There was no history of any smoking, alcohol, or recreational drug use. And we did ask specifically about other particular substances like stimulants, cocaine, methamphetamine, etc. And there was no recreational drug use on his history. His baseline vitals when he came to us was a blood pressure of 130 over 76 and a heart rate of 56. He had normal heart sounds, no extra heart sounds or murmurs. There was no signs or symptoms of heart failure when he was initially assessed in a clinic. And this was his baseline 12-lead ECG. So we see here that he's in sinus bradycardia with a rate of roughly 50 to 55 beats per minute. There's no clear conduction abnormality. He has a normal PR interval of 154. His QRS complexes are narrow. He's got a normal axis, and his baseline QT was about 405 milliseconds. So no evidence of underlying long or short QT syndrome. He did undergo an outpatient 48-hour Holter monitor. So his heart rate on the monitor on average was 78 beats per minute with a range from 46 up to 200. He was tachycardic 11% of the time, bradycardic 9% of the time. There was no prolonged pauses. He did have 66 beats of ventricular ectopy, and the fastest and most concerning of which was a 4-beat run at rates of around 240 to 280 beats per minute, which we'll have a look at in a second. And there were 34 beats of supraventricular ectopy as well, but no sustained runs. So this is a strip from his Holter. So we can see, looking from left to right, his baseline rhythm at the start is sinus rhythm to sinus tachycardia, roughly at a rate of 90 to 100 beats per minute. And then once we get to the middle of the strip here, he has what looks like a premature ventricular complex. And then that is followed by a 4-beat run overall of what looks like polymorphic non-sustained ventricular tachycardia. It looks to be almost bidirectional at times. And then after this short burst, he returns, has another normal sinus beat, followed by another premature ventricular complex. And then following that, he goes back into his regular sinus rhythm. So just one salvo of non-sustained VT here with polymorphic morphology. And based on those Holter results and his ECG, he had already done a exercise stress test as an outpatient. And so there's a few things that they commented on. One was on the Bruce protocol, he exercised for over 10 minutes, good workload. There was low risk of coronary artery disease from a stress perspective. However, the stress test overall was called abnormal due to an arrhythmia in the recovery period, which we'll take a look at. But before we do that, I just wanted to highlight also the importance of looking at the vital signs throughout the different aspects or phases of the stress test. So his baseline blood pressure when he started was 156/78 with a heart rate of 102. At peak stress, he had what looks like an exaggerated blood pressure response, with the blood pressure reaching 226/78 and heart rates up to 176. And then that blood pressure response was seeming to be sustained in the recovery period. So even 1 minute into recovery, his blood pressure was still 214/89 with a heart rate of 102. And then in the final recovery period, his blood pressure starts to come down a bit. So just something to keep in mind, that an exaggerated blood pressure response during an exercise stress test may indicate underlying latent hypertension, even when it's not overtly diagnosed in a clinic visit. This was the strip that he had 1 to 2 minutes into the recovery period. So again, when we're looking here from left to right, he's in normal sinus rhythm at the start. He does have pretty peak T waves, maybe a bit of high amplitudes at baseline. And again, here we see a premature ventricular complex along with 3 more beats of essentially non-sustained ventricular tachycardia. He then has another premature ventricular beat, and another one here, and then followed by a junctional escape beat, it looks like. There's no clear sinus activity here. And then after this, he returned back to his normal sinus rhythm. So another concerning salvo of what looks to be polymorphic non-sustained ventricular tachycardia with a quite concerning morphology. So because of this exercise-induced VT, we ended up admitting him to the electrophysiologic ward for inpatient workup to determine the potential etiology for his presentation. The most common cause of polymorphic ventricular tachycardia is usually ischemia. The other causes include underlying structural heart disease, so hypertrophic cardiomyopathy, ARVC, in which there's fatty deposits that get deposited into the right ventricular wall and can predispose you to ventricular arrhythmias. That's usually an autosomal dominant genetic inherited pattern, and other non-ischemic dilated cardiomyopathies. In terms of electrical issues, you can also have underlying channelopathies such as long or short QT syndromes, potential underlying Brugada syndrome, as well as catecholaminergic polymorphic ventricular tachycardia, which usually is another genetic condition that happens where most commonly there's a mutation in the ryanodine receptors, which enhance the calcium influx during ventricular depolarization and can predispose you to ventricular tachycardia as well. But these are mostly genetic inherited conditions. So we did a pretty thorough workup to investigate for all of these potential causes. So his baseline blood work was totally normal. He had normal electrolytes and renal function. His troponin was 3 when he came in, and his BNP was only 38. He had a baseline transthoracic echo with normal biventricular size and function. His EF was 63%. There was no significant valvular abnormalities. To assess or risk stratify him further for coronary disease, despite the normal exercise stress echo, we opted to do a coronary CT angiogram, given that he was only 28 years old and we had low suspicion for underlying coronary disease because he didn't have any strong family history or any of the other traditional risk factors. And the coronary CT did show normal coronary arteries. He then had a cardiac MRI to look for any structural cardiomyopathies. And again, no evidence of underlying ARVC or any dilated cardiomyopathy that we could see there. And so following this, he also had a genetic test sent for all of those other inherited conditions, long and short QTs, catecholaminergic polymorphic VT, and everything came back negative from his arrhythmia panel. So at this point, we were sort of at a loss. So as usual, he went for an EP study to see if we could induce what was going on here. And interestingly, he actually had normal conduction intervals. There was no evidence of any accessory pathways. He didn't have any dual AV nodal physiology. And during the EP study, they weren't able to induce any atrial or ventricular arrhythmias, which was quite interesting. So this is where we kind of went down the rabbit hole of doing more and more and more testing to look for any potential cardiac etiologies for his presentation. And at the end of the day, we didn't have a clear answer for it. So I guess like any good cardiologist would do in a patient with an underlying tachyarrhythmia and we don't know what's going on, we give him a short trial of beta blockers and see what happens. So he got one dose of Nadolol in hospital, 80 milligrams. And within about an hour or so, he started developing disabling headaches. He had some chest pain. He was getting flushed. He was diaphoretic and feeling nauseous, and also had a couple episodes of vomiting. So we weren't sure at this point if he was just having some kind of adverse reaction to the Nadolol, or what the underlying issue was. So we discontinued that, and we tried another beta blocker. We tried propranolol the following day. And interestingly, he had the same response here. So at this point, we kind of went back to the drawing board here, and reviewed what we knew about the case to try to form another differential diagnosis. So what we knew is this patient was 28, he was otherwise healthy, and he continued to have recurrent exertional symptoms, headaches, palpitations, pre-syncope, but no prior syncopal episodes. He had exaggerated blood pressure response during his exercise stress test, and he did seem to have these recurrent runs of polymorphic non-sustained VT with strenuous exercise. And he also has this markedly adverse response to beta blocker medications. So at this point, I think we had kind of all honed in on the cardiac causes of ventricular tachycardia and went down that rabbit hole. But I think it was time to start thinking of things outside of just the heart and cardiovascular system. And so something that we thought could potentially explain this was an excess catecholaminergic state, and potentially that adverse response that he had to beta blockers may have been because of unopposed alpha receptor activity, which you can sometimes see with catecholamine secreting tumors. And so the next step was to investigate him for a potential pheochromocytoma. So we sent off serum metanephrines, and they came back 5 times greater than the upper limit of normal. And the normetanephrines were markedly elevated as well. They came back at 12.4, and baseline should be less than 1. This was followed up with a CT of his abdomen and pelvis, and we can see here in the right side, mark it here for you, a large adrenal mass. The total measurements were 48 by 43 millimeters. And overall, given his clinical presentation, the location of the adrenal mass, the suspicion was for a pheochromocytoma. And so what we ended up doing was consulting endocrinology and endocrine surgery as an inpatient. We discontinued all the beta blockers and started him on doxazosin for alpha blockade. And then once he was sufficiently alpha blocked, we added on labetalol 1 week later. He was booked for an urgent surgical resection of the adrenal mass after a month of sufficient alpha and beta blockade, and the surgical pathology confirmed that it was indeed a pheochromocytoma. So this was a few months back now. So after his surgery was completed, we stopped all of his medications, and he had a 1 month follow-up with complete resolution of all of his exertional symptoms. The team over at UHN actually have implanted a loop recorder to see if he would have any recurrent arrhythmias despite resecting the pheochromocytoma. So I'm interested to see in the next little while what when he follows up again, whether or not he has any recurrent episodes, but we suspect all of his symptoms should resolve after this. So I just want to give everyone a little bit of a background on what a pheochromocytoma is for those who don't know. It's not a very common presentation. It's a rare neuroendocrine tumor. Originates from the chromaffin cells in the adrenal medulla. The incidence rate is about 0.66 cases per 100,000 people per year. Most cases tend to be sporadic, but up to 40% do have a hereditary component. So in those with pheochromocytoma, part of the protocol would be to investigate them for underlying MEN syndromes or multiple endocrine neoplasia, MEN1 and MEN2. And that would usually be done with an endocrinology referral. And about 10 to 25% of PHEOs do have metastatic potential, so it's an important diagnosis to avoid missing. In terms of the presentation, so most patients don't have the classic triad, which includes headaches, sweating, and tachycardia. The most common things that people do present with is just underlying hypertension, so either paroxysmal or permanent hypertension. And the cause of that is those excess catecholamines that the tumor is secreting are continuously stimulating your alpha-1 receptors on your peripheral blood vessels and causing vasoconstriction. So normally what we have is activation of beta receptors, most likely beta 2, which subsequently cause vasodilation to reduce that blood pressure response. So in these patients, if you start them on beta blockers, what you're doing is getting rid of that beta 2 activity and vasodilatory effect, and instead leading to unopposed alpha stimulation. And then the catecholamines can cause these hypertensive crises, which is most likely what we saw in our patient when we tried them on nadolol and then propranolol. In terms of cardiac complications of pheochromocytoma, there are a few kind of things to think about. One is myocardial ischemia, arrhythmias, and then the last is cardiomyopathies, which usually tend to mimic like a Takotsubo type cardiomyopathy from stress. In terms of arrhythmia, there was a study that was done in 2022 by Zhao and colleagues. It was a retrospective study to look at what kind of cardiac complications people with pheochromocytomas or paragangliomas had. They had 216 patients in that sample population, and 54 of those patients who had a combination secreting pattern, meaning they were secreting both epinephrine and norepinephrine, developed cardiac complications. Compared to only 13% of patients who secreted either epinephrine or norepinephrine. So an interesting pattern. And if you recall, our patient had elevation in both of those neurotransmitters. And of the patients that they had in their sample size, 21 of the 216 had arrhythmias. The most common was sinus tachycardia with 5 patients, AFib with 2, and then PACs and PVCs in a total of 11 patients. No patients in their study had any documented runs of ventricular tachycardia or non-sustained VT, which is what our patients seem to have been presenting with. So I delved a little bit deeper to see what the association was with VT and PHEOs and whether or not this was actually a common presentation of pheochromocytoma. And there was another literature review done in 2020 where Lee and colleagues looked at 15 cases of pheochromocytoma who initially presented with ventricular tachycardia. So it is a documented presentation. The average tumor size in those patients was 44 millimeters, and there was quite a large study base that demonstrated that tumor size for PHEOs is directly correlated with hormone levels, suggesting that larger tumors may have a higher potential for cardiac arrhythmias like VT. And our patients did have a 48 millimeter PHEO, so it's possible that this was what was predisposing him to having underlying VT compared to just other more common arrhythmias like sinus tach or AFib. And as we know, most patients after resection of a pheochromocytoma do recover completely. But of course, ventricular tachycardia can be fatal if coupled with VFib in patients who, if the diagnosis is either missed or delayed. So a few kind of takeaway learning points from this presentation. I think one important thing is to maintain a wide differential diagnosis, looking at both cardiac and extracardiac causes when we're treating or diagnosing patients with ventricular tachycardia. The, I guess, mistake that we had made early on was just honing into all of the cardiac manifestations and getting a bit of tunnel vision. And we forgot to think about some of the more common things like medications, extracardiac causes, drugs, etc., and electrolyte abnormalities, which are other common things that can lead to VT. The other takeaway is that pheochromocytoma should be suspected, especially in those patients who have polymorphic VT with underlying normal QT intervals, and there's no clear ischemia or structural heart disease, right? So of course, when you have polymorphic VT, you don't want to miss ischemia or heart disease that with the underlying structural component. But if you have normal QT intervals, the kind of red flags should be going up. Is there something extra cardiac that we're missing here? And then in terms of the management, again, avoid beta blockers in the initial management of pheochromocytoma. You start with alpha blockers first, and if they're sufficiently alpha blocked and you still need to give them beta blocker for tachycardia or hypertension, etc., then you can do that once they're appropriately alpha blocked, because unopposed alpha receptor activity can lead to hypertensive crises. And the last and kind of biggest takeaway in a more general perspective is if you're dealing with a patient who has a seemingly elusive diagnosis and you're not sure despite doing a whole host of tests, always reevaluate the history, the physical exam, and see if there's anything else that you can kind of point to that may push you in one direction or another that you may have missed the first time around. So I think that that's an important part of clinical medicine is to always go back and see if you kind of missed anything that may help you with elucidating a tough diagnosis. So these are the references for the talk today. And at this point, I'll be happy to take any questions if anyone has.
Okay, Chai, thanks for sharing this fascinating case. I'm sure the team will have questions for you because I could certainly see if the patient has syncope, patient goes
Yeah.
to the device. Is that why there has been some I guess a trial of medical therapy before?
Yes, well, I guess the underlying issue we had was the patient was symptomatic with exertion, and we hadn't fixed his underlying problem. And on the EP study, we also couldn't induce any of the arrhythmias. So we thought maybe we would try a beta blocker and see if we can help with his exertional symptoms and reduce the recurrence of his VT. But um, unfortunately, that didn't happen. But it helped us kind of figure out what the diagnosis was when he reacted so poorly to the beta blockers. Yeah. Hey, Dr. Connolly.
Hey, Chai, good, great, interesting case. You mentioned the stress test and the blood pressure response. Do you think that
Yeah.
was real? What's your interpretation of a blood pressure 226 in a young male or an athlete? Is that hypertensive or not? I know we've got Ryan Sless on the line, and he did a lot of analyses of at least in athlete population. So, wondering what you think about that.
Yeah. Well, we'll ask Ryan to see if he has any insights as
Yeah.
well. But for me, I think 28-year-old gentleman, he was healthy, he was not obese, he was actually quite active and fit at baseline. To see this kind of exaggerated hypertensive response, I think what it may have been alluding to is that he had some underlying latent or paroxysmal hypertension to begin with, that was exacerbated with exertion. And with pheochromocytomas, we know that about 50% of patients do have some underlying hypertension, whether it's diagnosed or not. So I think maybe that was an early clue that we were dealing with an excess catecholaminergic state, but it's hard to kind of go back and say. I don't know if Ryan has any inputs or what you saw in athletes.
Yeah, I
Well,
mean, it's hard. It's sort of so non-specific. Finding. It certainly wouldn't be one that I would go back and say, gee, you missed anything. I would have said, hey, in retrospect with a Theo, of course you're looking for any clue, but I guess the main message is I don't want people to think if they see that response, that they should then consider a Theo there. And I mean, Ryan, you might want to comment on your study in the athlete's hearts population. And now I know Ryan's study was specifically looking at athletes, but I think it's worth a comment there, Ryan, if you want to fill everyone in on what your data showed.
Yeah, sorry, I just had to step away for a second, so I missed the beginning of that. But yeah, so we looked at high trained endurance athletes who have, like hundreds of hours a year of exercise, a lot of like Iron men, Iron women. But basically, we found that compared to the normal population, there was like 50% of people that had this so-called exaggerated response, as opposed to in the normal population, it's like 7 to 8% or so based on Framingham data. So, presumably for everybody, it's not necessarily a pathologic response, but is sometimes considered a physiologic response. And with that too, even looking at kind of our recreationally active control group and looking at our athletes, we did find that people, the average exaggerated response was 220, 230. So there are lots of people that still have much higher blood pressure responses. And part of that could potentially still be physiologic and is not necessarily pathologic. So just things to keep in mind that, maybe we need to do a bit bigger, deeper of a dive as to what actually qualifies as an exaggerated response. And interestingly, we wrote a review as well, went back to like the 1940s when it was first published, and it was really just a random number that was picked as a top 10 percentile of responses. So it wasn't actually based on anything significant, but they just randomly selected that number essentially. So it's just with a grain of salt to take it.
thanks, Ryan. Like, what about the diastolic pressure in those?
Yeah.
Because I mean, usually the diastolic drops during exercise, and was that something? Is that a consistent finding? Because here there's no change in diastolic pressure.
Yeah, I mean, typically the diastolic pressure went up a little bit at the beginning, but then with steady state would fall again. And unless, there's some data that shows that people that have increases in their arterial stiffness as measured by pulse wave velocity do have a sharper rise in their diastolic pressure. But definitely there is more of a signal towards some sort of pathology in people that have persistently elevated diastolic pressures with exercise, I think, than systolic.
Okay, thank
Thanks,
you.
Ryan.
Okay,
Yeah.
Dr. Abramson.
Yeah, excellent and interesting case. I think also though, you've concluded that while we have to think outside the box for non-cardiac issues, not everyone coming to us with chest pain or palpitations has a pheochromocytoma. So I guess one of the challenges I was going to ask about blood pressure as Dr. Connolly had. I would challenge every trainee who's on this call to make sure you've actually supervised stress tests and try to check blood pressure, because it's actually technically a challenging it's challenging to do. And I think as the healthcare providers, we need to make sure we understand the tests and make sure they're accurate, and make sure, and in this case, it probably was, that the data that we've collected is accurate as well. It's just a sidebar, but very interesting talk.
Yeah. Thanks, Dr. Williams.
So along this line, Chai, is so for a lot of us non-electrophysiologists, we see a lot of halters, and it's not unusual to have sometimes short, non-sustained VT. So maybe you could go over your approach to which ones you may not really go the full speed workup, and which ones you would. I understand it's polymorphic, but for a lot of short, non-sustained, they're not usually monomorphic. They could be
Right.
different morphology because they're only 3 or 4 beats.
Right. No, that's a good point. I think one thing is the presence or absence of symptoms. For our patient, he was clearly coming in with exertional symptoms, which is why these tests were done in the first place. If the patient has underlying symptoms that may correlate in a symptom diary or in general to those runs, then probably it's worthwhile being more aggressive in terms of investigating further to figure out the cause. The other part would be the frequency or how often they're happening, right? We didn't see them happening too often. He had one episode in a 48-hour Holter. So it did get picked up in that sense, but it wasn't like he was having recurrent runs multiple times a day. So I think that may be the other consideration. Whether or not there's any sustained arrhythmias would be concerning as well. So anything lasting for over 30 seconds or associated with any form of hemodynamic instability, I think should be appropriately worked up. I think there's a few different
so if you have a patient with, let's say, asymptomatic Holter findings of, let's say, 8 beats of non-sustained VT, how would you do? What would you do? Anything? And again, I'm interested to hear Paul Angern's thought and the electrophysiology team.
I think one thing is I would, if they're having runs,
let's say, and not correlated with symptoms. It just it was done for some for symptoms, but it did not correlate with symptoms.
Right. I think baseline, at least I would do a 2D echo and to look for any signs of underlying structural heart disease. So they may have underlying ischemic or non-ischemic cardiomyopathy, low ejection fractions. If you're having runs of non-sustained VT in a patient with structural heart disease, that may even be an indication for ICD implantation. So depending on what the underlying structural heart looks like. For those patients, I think starting off with at least an echo is a good idea. But if they're asymptomatic, the VT is not bothersome, there's no indications for ICD or anything, then I think it may not be worthwhile going down this kind of rabbit hole and just doing unnecessary testing.
Paul, is this your approach?
Yeah, I think that's a reasonable sort of approach to this problem. It's a common finding. We see it a lot, and particularly in older patients with heart disease, anything from AS to, a bit of coronary disease. Largely, I think echo is reasonable just to make sure the EF isn't terrible. We often do this we see this all the time in pacemaker patients. The ICD patients we can exclude because they already have a defibrillator, so they're already protected in a sense. But we commonly see non-sustained VT in pacer patients, And at most, we will just ask if they have symptoms related to that and do an echo. And rarely is the EF down in these patients with pacemakers. So it's don't know why it happens, but it's not necessarily a poor prognostic marker if your heart's structurally normal.
Okay, thank you. We have a question from Haitham Sharar. He was wondering about your choice of nadolol. Why nadolol and not propranolol or other beta blockers?
I think the main concern was that he was having these hypertensive crises, so we wanted to go with something that was not as cardioselective and may have more activity on the alpha receptors to at least bring down the blood pressure, because we were wondering if the exertional symptoms that he was having was associated with this exaggerated blood pressure response that he had. So that's why we went with something like a nadolol or propranolol over metoprolol, carvedilol, something like that. But apart from that, I don't think there was any other great kind of rationale for why that was picked specifically. But in retrospect now, I think that the fact that we did use non-cardioselective beta blockers probably made his hypertensive crises worse than maybe a cardioselective beta blocker would have.
Why did you choose nadolol over propranolol?
Nadolol over propranolol? I don't know. I don't remember. I don't know.
You generally use it for in diseases that are adrenaline mediated because it's more potent
Okay,
than propranolol.
interesting.